Thank you. And actually, I'm presenting for one of my bosses, Radonna Chandler, although if I make any errors, those belong to me. What I'd like to do is to highlight NIDA's efforts in the area of treatment as prevention. And as suggested by the name of our institute, our emphasis really is on HIV in drug-using populations. And what I'd like to do is to talk a little bit about our current portfolio. I think people who've come to this meeting in the past, for some of you, this may be a bit of a review. And I'd also like to talk about our future directions, the things that we're thinking about, the kinds of studies we'd like to be encouraging, which actually follow on very nicely with some of the other presentations here and yesterday in terms of emphasizing implementation. Where we come from in terms of the foundations for a treatment as prevention approach is a long history of supporting research that has tried to increase testing among marginalized drug-using populations using a variety of different strategies. And you can see that when people think about drug use, they often think about injectors, but in fact, drug use is common in a variety of populations and settings. We also have a long history of supporting research related to engagement in care and adherence, both for drug treatment and for HIV treatments. And just to give you some idea of what we've been doing, over time, a much larger and larger proportion of our portfolio has been devoted to a test and treat approach. We refer to it as seek, test, treat, and retain, and building on some of the work done here in British Columbia, some of our emphasis is probably more on seeking out people at high risk than some other research programs. But you can see that over time, we have been doing more related to retaining and care, and in general, devoting more of our portfolio, our dollars have been constant over this time, to studies that get at seek, test, treat, and or retain. In terms of our signature projects, I want to talk about 3 large grant programs that we've funded. The first was looking at a seek, test, and treat approach in the criminal justice system. And as you may or may not be aware, in the United States, and these were all domestic, with one exception, projects, and internationally, the criminal justice system often has a large proportion of people in that system are people who are involved with some kind of illicit substance, alcohol, or sometimes other illicit substances. And as you can see, these projects are all over the United States. Some are in jails, some are in community corrections where people are under supervision, and some are with prisons where we're particularly focusing on release. We followed that program announcement with one that was looking at vulnerable populations, which the way we think about vulnerable populations really includes the traditional high-risk groups, including high-risk heterosexuals. And these are, as you can see, in different parts of the United States and also much more distributed internationally. And some of the PIs for these projects are here in this meeting. And then more recently, we partnered with PEPFAR for an implementation science announcement and funded a number of international projects, many of them concentrated in Southeast Asia, where we also have other ongoing research. But the emphasis here was more on how you would do implementation. So some of these studies look at adaptation to new settings. And like the others, they emphasize usually 2 or 3, but not necessarily all of the elements of seek, test, treat, and retain. In addition, our clinical trials network is funding a number of large studies. One is working to identify crack cocaine users in a number of U.S. hospitals. This is being done by Lisa Metch and Carlos Del Rio, and this is following up some earlier work that they did with interventions with crack users in hospitals. And I think Lisa is at this meeting, so you would be able to talk with her further about this. We're also supporting a hospital-based cluster randomized trial for testing and linkage to care in China, and I believe Dr. Wu is here and could talk to you further about that. In terms of future directions, I think in common with the other speakers here, both this morning and yesterday, we recognize that it's important to be able to take research findings and bring them to scale. Most of the studies that are mentioned on the slides are efficacy or effectiveness studies. So we really need to be able to move from efficacy and effectiveness to actual implementation and to provide models for how to put things in place. And from our perspective, this involves systematic, in other words, replicable, measurable strategies for promoting adoption of evidence-based practices with fidelity in routine clinical settings. And approaching dissemination and implementation as deliberate actions. So thinking about those as interventions that would be the focus of various kinds of randomized hypothesis-driven designs. And one way to think about this process is to think about our toolkit. So NIDA has supported a number of approaches to seeking people out, engaging people, providing HIV testing, promoting adherence, linkage to care, and a number of these are listed here. So, from our perspective, in part because of the status of syringe services in the United States, we do research in those settings, although we don't do research that necessarily sets up those settings. We've looked at opt-out testing approaches, partner notification, adherence interventions, directly observed therapy both for drug use and for HIV, and we have a number of interventions in the field looking at patient navigation, strengths-based case management, and incentives. And as you can see, these parts of these tools can be used to help move people along through the treatment cascade. And so one way to think about this is you have the cascade, you have tools to move people forward, and then you have to think about how you can get people to make more use of those tools. And like other people here, we've had the observation that if you build it, people don't come. Drug treatment programs still don't screen. In fact, screening for HIV and HCV in drug treatment programs in the United States has actually declined. Opt-out screening coverage often is incomplete. Linkage in practice is often a rather passive process. Services remain poorly integrated even where systems are supposed to be working together. So for example, our Ryan White clinics often deliver some types of drug counseling, but not necessarily medication-based drug treatment. Drug treatment settings often don't provide much in the way of HIV services. Another consideration is that people enter, leave, and sometimes don't re-enter treatment. And that's true for HIV, it's true for drug treatment. And so we have to think about this as something that isn't entirely a linear process in practice. Okay. And then there's also the issue of providers not using effective programs, and policymakers' questions often not being very well addressed by research, that often the cost of programs, the logistics of programs, often aren't the focus of research studies. So if you want to do, for example, an HIV testing study and approaching it from an implementation science perspective, what would it look like? And so I want to provide a very brief example. We ask that you not submit this particular idea, but in this case, thinking about not so much the individuals, but thinking about the settings. In this case, it might be the outpatient drug treatment settings. You would look at the characteristics of those settings in terms of being able to adopt new practices, the organizational readiness, staff attitudes, and then you would think about randomizing these treatment sites to different approaches to implementing programs. So it might be different ways of publicizing, as in this example, different ways of training and reminding members of the treatment team, and then setting benchmarks in terms of the amount of uptake that you would like to attain, and begin thinking about sustainability measures and how you can build those into a research design. What are the things that help sustain programs, and how can you build in quality improvement components to make those happen? And so what we're trying to encourage is more emphasis on implementation science. As people's efficacy and effectiveness trials are completed and we have findings to move into the field, really the next step is to think about what are the facilitators, what are the barriers, what kinds of things can we do to target providers, organizations, and systems. How can we think about combination strategies, which in our case also incorporate attention to the prevention or treatment of drug use, and thinking about how these things can be adapted to different areas, risk groups, and age groups. And we're also working with the Alcohol Institute. We have what we've described as a functional integration, which we're still trying to figure out, but to better think about overlapping issues with alcohol and illicit drugs. Something else that we're also supporting is the development of new research methods to be able to do optimization trials to figure out how much of a dose of an intervention or in what way it's best delivered, and sequential trials where you have to think about multiple clinical interventions for people. Do you start with drug treatment? Do you start with HIV treatment? What do you do if people have to proceed through multiple treatments and have treatment failures? So in addition to this more substantive clinical work, we're also looking at trying to develop new research methods, ways to make this kind of research more efficient. Okay, thank you.